This is the title of my talk, Can PSVD Lead to Cirrhosis? I have no commercial disclosures. I'm very grateful to be here, and I want to emphasize that what I'm going to present is as a personal citizen, not as a representative of any organization. So again, when we don't have much data, we have to start with philosophy. And much of liver disease is progressive, and that's usually in the presence of an ongoing driver. And even in a disease that does progress, think about hepatitis C. Not all patients do progress. Some don't. And if you do progress, those who do progress don't progress at the same rate. So we shouldn't expect PSVD to be different. And in PSVD, portal hypertension may progress without an increase in fibrosis. We have evidence for that. We see patients with advanced portal hypertension without significant fibrosis on biopsy, patients presenting with variceal bleeds. We published an autopsy series with patients who died, some with liver-related disease, and none had cirrhosis but had PSVD on autopsy. And there is an implication, there is some data that this might have a non-fibrotic or perhaps some fibrotic correlate. Zhang et al. Have published 2 papers where they showed that pseudolobule formation, that's their term, is associated with more advanced disease. There would be a non-fibrotic correlate of more advanced disease. And they also published more fibrosis around the portal tract. So there is some evidence, but that's not cirrhosis. What about non-invasive tests? Elastography can increase. We've got to be careful because elastography can increase for other reasons too. Portal vein thrombosis, acute infection, congestion, technical reasons. But there are cross-sectional studies which suggest that it may progress slowly, even in non-fibrotic disease. There are other things like platelet slopes, spleen height ratio, and I think the spleen height ratio is perhaps a more rigorous way to look at splenomegaly. Spleen liver stiffness ratio, very important. And I want to just look at a platelet slope because I'm going to come back to it later. These are 2 patients with CGD. The first patient, patient A, had a slope of minus 26,000 a year, and that patient ended up dying with PSVD. And patient B, also with CGD, similar number of infections, actually also had an infection at the terminal point of this curve, but that wasn't terminal for him. And his curve was flatline, here a good thing, did not have PSVD. So platelet slope is helpful over time, but you need longitudinal data. What about nodules and fibrosis? And forgive me for being simplistic here. I know Ian Wanless is correct, cirrhosis is a vascular disease, but I'm going to go through some very simple thoughts. Fibrosis can be part of PSVD. We already said that. Cirrhosis is a diffuse disease. It's fibrosis surrounding nodules, like this. I want to thank David Kleiner for all the pathology. And nodular regenerative hyperplasia is diffuse, nodules without surrounding fibrosis, like this. So let's think about cirrhosis. In hepatitis C, you slowly get progressive fibrosis, and then at the end, you get fibrosis surrounding them. You get nodules forming within that fibrous network. It's been known for a long time, going back to the 1800s, that primary biliary cirrhosis can present as nodules first, and then only late at the end of the disease, develop fibrosis. And that's continuously published, the most recent paper I listed there. So the hepatic repertoire of responses is important to think about, and the sequence can vary, right? You could get fibrosis and then nodules, nodules and then fibrosis. I just want to mention, we've discussed this already, but fibrosis regression, it may resolve, but portal hypertension may persist. It may then look like PSVD, and just an example of that was with hemochromatosis. And fibrosis in this setting would not be progressive. That's not what I'm talking about. Okay. Limitations of the sort of topic that I've been given, and maybe the field, is that up till now there's been lack of universal definitions, lack of prospective studies. There are very few prospective studies ongoing. Lack of prospective studies with serial biopsies ongoing. Bundling of multiple etiologies and multiple stages of severity. Kind of no choice with that with a rare disease. You sort of have to do that. So, finally, the question, can PSVD lead to cirrhosis? And my answer is, I don't know. But let's talk about CVID. common variable immunodeficiency. It's not common. It is variable to some extent in terms of cause, but it's not really variable in terms of what you see. This is one patient, and his initial biopsy showed NRH. You can even see that on the meson. You can see the nodules. You don't have to be that hot cluster there to notice that. And then in the second biopsy, you can see the fibrous tissue, the blue, the dense bands of fibrous tissue. And this is, to quote Dickens in Paris, a tale of two studies, a tale of two biopsies. And there are two studies really that look at this, and I'm going to go through both. The first is Silva et al., the Journal of Clinical Pathology last year, and they called it NRH-like changes were seen in 80% of the patients, 32 out of 40. All biopsies showed fibrosis, pericellular in 52%, but really interesting, bridging fibrous septa in 19, or 47.5%. And 5 out of 7 with 2 biopsies showed progression in fibrosis stage. They didn't detail really, it wasn't clear to me which of the 7, so I didn't list sort of the progression, but let's go to the next study. Julian Herkoon is a phenomenal hepatologist. He's now at Montreal. He was a fellow with us. And we looked at 40 patients. At the initial biopsy, 73% had NRH, initially with a median fibrosis stage of 1. And at the time of biopsy, 38% had signs of portal hypertension. And over 5 years, 65% developed signs of portal hypertension. And that's progressive disease. Right? Clinically, that's progressive disease. Let's go to platelet slope. So here, we graphed just those who started with platelets over 100. And we tracked all the platelets that they had measured over time. And some of them had more than 30 years follow-up. And you can see that the platelets decline over time. So we have clinical progression, and we have platelet progression, platelet slope progression. So what about the meat of it? What about the second biopsy? 16 patients, for clinical reasons, not per protocol, but clinical reasons, had a second liver biopsy, a median time of 3 years later. And the increase in fibrosis was by more than or equal to 2 stages in 31%. So think about that. 2 stages in fibrosis, 31% over 3 years. That's pretty rapid. That's not trivial. And an increase in overall stage of 2.2 with a significant value of, you can see it's significant. And when we graph that out, on the left-hand side, you could see first to second biopsy paired analysis. Only 3 of the 16 didn't progress. And if you remember the early data with hepatitis C, Harvey Alter studies, or hepatitis B, when people were biopsied every 5 years, some regressed, some progressed, some stayed the same. There's no regression here. Everybody progresses and a few stay the same. And if you look at the percentage of cases with the different stages, with the different histologic fibrosis stages, you can see that there's a real transition from first biopsy to second biopsy. You see the appearance of cirrhosis, you see the disappearance of zero fibrosis, and the disease becomes very fibrotic. So, is there evidence that PSVD and CVID might progress? I think yes. I think there's enough evidence to be able to say that. There's proof of concept. I have to ask, is CVID a different disease? Because remember the autopsy series and the biopsy series in different patients with more advanced portal hypertension? So is CVID really a different disease? Is it more like PBC, where the nodules occur and then the fibrosis occurs later? Maybe because it looks like PSVD initially, it's not really. I don't know. And is this true in all PSVD? I think most likely not. Is it true in other causes of PSVD? I think we need to see. We need longitudinal prospective studies. We need multiple etiologies, and we need serial biopsies. We really do. You know, to go back to the pathology, we need people who do not have portal hypertension, of early disease, to come into studies. We need people to come into studies and referral to the expert centers with portal hypertension without decompensation. And then we need to be able to follow them clinically and their biopsies to understand what happens with the disease. So, I know it's not a very strong conclusion, proof of concept in CVID, but for the rest, probably not. Jury's out. I want to thank the organizers again. I try to keep to the 10 minutes. I want to thank David Kleiner because without the pathologist, for me, nothing is possible. And then the other people who have collaborated. And this is something I really like. It's reminiscent of the medical symbol, but it's a caput medusae in a patient with CVID who had a Carvalho-Baumgarten syndrome and decompensated and died. So, thank you very much.
Thank you very much for a very nice presentation. Are there any questions?
Thank you for your presentation. I just wanted to make a comment on the other study. I was sort of participated to that one. And what we noticed also was that the variation in progression of fibrosis and severity in general was also related to age at presentation. So it may be that even in the CVID cohort, there is also heterogeneity, maybe due to some underlying genetic factors. And so you have some patients maybe present earlier with more severe disease who then will progress faster at an earlier stage.
Yes, I think you may be right. There's definitely genetic heterogeneity in CVID, and the different presentations. Granulomatous lung disease is only seen in a subgroup of the patients, and the severity is the progression and severity may be associated with some of that. We looked at some of the genetics. Not all of it is known, but there was nothing obvious in this group of patients.
Thanks.
Thank you for your comment.
Yes, thank you very much for your very, very thoughtful presentation. I'm also wondering whether CVID is a different disease from the rest of PSVD, as you put forward, because some of the CVID patients on biopsy have inflammatory infiltrates that very much look like immune-mediated liver disease, autoimmune liver disease, which, I mean, all immune-mediated liver diseases also cause some kind of irregular fibrosis and nodularity. So maybe it's a different entity.
This is a fantastic point. And what I didn't address is that many of the CVID patients have an autoimmune hepatitis-like picture, and some of the early literature describes that. We found progression in those with florid inflammation and in those with less inflammation. So I didn't include that, but that's something we've been thinking about as well. I think it's important. Thank you.
Maybe probably one comment from my side. Nowadays, guidelines also allow that patients with PSVD might have some mild other underlying liver disease. Should we stay aware that these other liver diseases could probably also progress? And should we probably change the label or be open to change the label of patients from PSVD to cirrhosis at some point in their history?
Yes, I think this is a very important point. And we've been referred patients labeled with a biopsy showing PSVD, and then they get to us and we re-biopsy them and they do not have PSVD, they've progressed with other underlying liver diseases. And that's why I think the concept of -1 point for presence of other liver disease, and things like, and being aware of what the other liver disease is and being sensitive to that is very important.
Mm-hmm. I have a quick question. Thank you, Theo. Yeah. I have a quick question, actually a comment. Like you mentioned something very interesting about these patients with common variable immune deficiency, that they have feature of autoimmune hepatitis. Some of them that I've seen as second opinion were already on Imuran or azathioprine as well, which kind of introduced a confounder and this, associated condition basically. Like, is what we're seeing because of the treatment they're on or because of the disease?
Yeah, I have seen patients with CVID on azathioprine.
Yes.
Generally, they don't do as well. They often get more infections. None of these patients were on azathioprine. Mm-hmm. But that's also an important point.
Thanks.
Hi. The other situation that we can face, and which is not very agreeable, is that we have a patient who had a liver biopsy a few years ago, saying this is really PSVD for sure. And then you don't see the patient for some years. He has liver transplant, and on the explant, it's cirrhosis. So were we wrong at the beginning, or is it just that the outcome is finally cirrhosis? And the question is, do you think if we pooled because I'm sure we are not the only one, I hope I'm not the only one to have been in this situation. Do you think that we can advance and find some tools to answer to the question, was it PSVD or is it finally cirrhosis, and the file was not well seen?
I think I don't think you are wrong. I think you have to, at the time of diagnosis, you have to do the best you can with the data you have. And the horrible thing about patients is that they change. They don't listen to us, and they don't like being labeled. And, we should label wine, but not people. So I think it's hard. It's hard to hold yourself to a standard that's 100%. We've seen expert pathologists, expert clinicians. We can't. I do think we have to be open and sensitive and curious and always ask if there's a clinical change in the patient, what's happening? And I think that the question that you asked, Bernard, is very important because we sometimes miss associated liver conditions or other things which may progress to cirrhosis. And the last thing is it's very patchy. We had a patient with sickle cell anemia, and the radiologist had a student, and so please don't, I shouldn't say this in public, switch off the camera. They biopsied both lobes. We wanted one biopsy, and they biopsied both lobes. And the one lobe had absolute PSVD, and the other lobe was completely normal, except for the sickle cells. So that was very instructive for me. And we've been measuring HVPG in both the left and the right, and if we can't get into the left, we'll do it in the middle. And we often find discrepancies. The problem with that is the right is not the same as the left, and it fits with the radiology, but I think it's patchy too. Yes.
Two things. One question, which is how to get involved in this study. The person says, I cannot find how to get involved. So this is a very important point, and thank you for asking this. It's very simple in the Valdic studies that have been alluded to. Juan Carlos showed one published, Pierre Deltan, another which is ongoing, etc. It's very simple. First step is to become Valdic member. So it's free. There is never things to pay, so that's good. And you just send your CV application, and the steering committee of Valdic assesses, and providing you have some interest in the vascular liver disease, usually we can say that you're accepted. And then you have access to all the studies that are ongoing, and you can participate to all the studies. And on Valdic website, you can see there are plenty of studies that are currently ongoing. So this is a very good point, and please do not hesitate to join. Just type on Google Valdic and you'll find Valdic website immediately. This is the first
Even Americans?
I'm sorry?
Even Americans?
This is, this is not European organization. This is any country can join. And in the publication, there is commonly a patient from non-European countries involved. So yes. And the second question was, can you comment on the occurrence of hepatocellular insufficiency in advanced stages of PSVD? And the cherry is the mechanism.
So two brief things to say to that. The first thing is that one of the things that I noticed first, the NIH is a funny place. Patients are brought in per protocol, so if the principal investigator leaves or stops studying it, we don't see those patients anymore. So when I first started, we saw a lot of patients with sickle cell. We don't see patients with sickle cell anymore. But what I noticed was when they came into the ICU and they were sick, some of them became jaundiced and developed ascites. Those were the ones with PSVD. And those who came to the ICU and got sick and didn't develop jaundice and ascites did not have PSVD. We were biopsying for iron as well. And I think the increase in portal pressures and the increase in portal hypertension in a critically ill patient is well documented. And that there's the equivalent in PSVD is very interesting. We even saw hepatorenal syndrome. In the CVID patients specifically, what first made us think of putting this together was that we noticed we had a patient who decompensated. INR went up, bilirubin went up, albumin went down, developed horrendous ascites. And then on autopsy, he had cirrhosis. And so that made us think, so then decompensation in this setting may be the development of cirrhosis. And then one more thing, go back to the decompensation in the PSVD patient in the ICU. When they get better, the ICU goes away by itself, so you have to remember to slowly withdraw the diuretics. Because as they get better and the need for the diuretics goes away, the ascites will resolve. So that also made me understand it's not cirrhosis. Yeah, it's more of an acute portal pressure increase.